So although I think there's a valid question to be asked about whether or not disease-free survival is the appropriate endpoint for evaluating a targeted agent in a group of patients who are at high risk of relapse, assuming that osimertinib becomes the standard approach in resected patients, I think that what to do in patients who progress is going to be a question that that we will have to be dealing with. I think that there will be basically two scenarios in which we are dealing with this. One is patients who progress while receiving adjuvant osimertinib. And I think in that group of patients, things like chemotherapy would likely be what we would look for. We would look for clinical trials on some of the same approaches, what the role of approaches such as what was seen in the relay, which was erlotinib, bevacizumab is unclear. Obviously, there will need to continue to be genotyping, looking for bypass mechanisms and secondary mutations, as has been done in patients who progress with known advanced disease. The other group of patients are going to be people who progress after they have completed their treatment with osimertinib in the adjuvant setting. And although we don't have a lot of data at this point, I think that that's a group of patients, again, where the consideration may be, perhaps depending on the length of time, in many of those cases there will be a consideration of returning to osimertinib. But again, there may be some circumstances in which something like the combination of erlotinib ramucirumab would be reasonable, depending on timeframes and things like that.